Nursing 345, Anus, Rectum, and Prostate. The objectives for this week are to assess the composition of breast glandular tissue, describe the ways of documenting clinical findings from a breast exam, relate the anatomy of the breast lymphatic system, cite the location of superficial groups of lymph nodes that are accessible to examination, discuss the importance of teaching testicular self-exam as health promotion during assessment, describe developmental care for examination of anal, rectal, and prostate structures, incorporate health promotion concepts when performing an assessment of the anus, rectum, and prostate, outline the changes observed during puberty, and acknowledge and include health promotion concepts when performing an assessment of the female and male genitourinary system. The anal canal is the outlet of the gastrointestinal tract. In addition to autonomic nerves, numerous somatic sensory nerves are present and make the area sensitive to pain. Internal and external sphincters surround the canal. The external sphincter provides voluntary control for the expulsion of feces and gas. Anal canals in the rectum end at the anorectal junction and contain an artery and a vein. Enlargement of these veins forms hemorrhoids. The rectum is the long distal portion of the large intestine, extending from the sigmoid colon to the anal canal. The peritoneum covers only the upper two-thirds of the rectum. The sigmoid colon extends from the iliac flexure of the descending colon to the rectum. It is 40 cm long and S-shaped and can be examined only during a colonoscopy. In men, the prostate gland lies in front of the anterior wall of the rectum and behind the symphysis pubis. It secretes an alkaline fluid that helps sperm viability. Two seminal vesicles project like rabbit ears above the prostate. They secrete a fluid that is rich in fructose, which nourishes sperm. In women, the uterine cervix lies in front of the anterior rectal wall and may be palpated through it. At different developmental stages, certain anatomic changes occur. In newborns, passage of the first stool, which is meconium, indicates anal patency. Usually between 1.5 and 2, the nerves of the rectal area become more myelinated. Toilet training usually starts after this age. During male puberty, the prostate grows rapidly, doubling to reach adult size. At age 40, benign prostatic hypertrophy is present. It becomes larger with age and is thought to be caused by hormonal imbalance that leads to the proliferation of benign adenomas that gradually obstruct the urethra. Culture and genetics. There's risk factors for prostate cancer, which include increasing age and specific ethnicities. Environmental factors may also account for more risk than genetics. Diet and obesity may increase the risk of prostate cancer. Prostate cancer screening recommendations for various racial groups. Men at high risk, Black men, and men with first-degree relatives with disease should begin screening at age 45. Colorectal cancer has a racial variation as well. Incidence in Black women and men is almost 20% higher than in white women and men. Mortality is 50% higher in Black men and women than in white men and women. For subjective data for the anus, rectum, and prostate, the clinician should discuss the patient's usual bowel routine, any changes in bowel habits, and rectal bleeding or blood in the stool, the use of medications, rectal conditions, and also family history. So on the slide you can see there's questions that you can ask your clients. Self-care behaviors such as high-fiber diet and colorectal cancer screening should also be, you should also ask your client that as well. So as you can see, the questions are listed on the slide. Do you have a family history of polyps or cancer? Do you eat a usual amount of high-fiber foods in your daily diet, such as cereals, apples, or other fruits? Do you drink water? What were the last dates of your digital rectal exam? Did you ever have your stool tested for blood? Did you ever have a colonoscopy? Men, when was the last time you had your PSA blood test? For subjective, this is just for the objective exam. This is just positions. To obtain objective data, first inspect the perianal area. Observe the anus and perianal region while the patient is relaxed, and again while the patient performs a Valsalva maneuver. The anal opening should be tightly closed and no lesion should be present. Inspect the sacrococcygeal area, which should appear smooth and even. Any abnormality should be described in clock face terms. Next, palpate the anus and rectum with your lubricated and gloved index finger. Using only the pad of your index finger, assess the surface of the entire muscular ring. To assess muscle tone, have the patient tighten the sphincter around your finger. Use bidigital palpation with your thumb against the perianal tissue to highlight swelling or tenderness and assess the glands. Insert your finger further and examine the entire rectal wall. Inspect any feces that remain on the glove and test any feces for occult blood. Through the anterior wall in a male patient, palpate the prostate gland. Note its size, shape, surface, consistency, mobility, and sensitivity. When assessing the anus, rectum, and prostate, incorporate health promotion. For example, encourage adults aged 50 and older to have regular colorectal screenings. Explain that tests identify precancerous polyps and can detect colorectal cancer in the early stage when treatment is most effective. Palpate the cervix in female through the anterior rectal wall. It normally feels like a small round mass. May palpate retroverted uterus or tampon in vagina. Withdraw exam finger. Normally no bright red blood or mucus is on the glove. To complete the examination, offer the person tissues to remove lubricant and help person to a comfortable position. So your checklists for the anus, rectum, and prostate include inspect anus and perineal area, inspect during Valsalva maneuver, palpate anal canal and rectum on all adults, and test stool for occult blood. This next slide is your sample charting slide. So for subjective data, it says has 1 BM daily, soft brown, no pain, no change in bowel routine, on no medications, has no history of pruritus, hemorrhoids, fissure, or fistula. Diet includes 1 or 2 servings daily each of fresh fruits and vegetables, but no whole grain cereals or breads. Objective data includes no fissure, hemorrhoids, fistula, or skin lesions in perianal area. Sphincter tone good, no prolapse, rectal wall smooth, no masses or tenderness. Prostate not enlarged, no masses or tenderness. Stool brown, hematest negative.